Assalamu alaikum. This lecture is about surgical liver diseases. This is just to show you how a normal liver looks, and these two slides will show you how an abnormal liver looks. Now, just to remind us about the anatomy of the liver, we have four loops, right, left, caudate, and quadrate, and there are three blood vessels supplying the liver: hepatic portal vein, hepatic artery, and hepatic vein. And these are the segments of the liver. The etiologies we are going to talk about in this lecture: abnormal liver function test, non-alcoholic fatty liver disease, primary biliary cirrhosis, primary sclerosing cholangitis, hepatocellular carcinoma, and metastatic liver disease. Now, the abnormal LFTs. The asymptomatic elevation of ALT probably is the most common presentation. If it is isolated and less than threefold elevation of the normal, then advise your patient to stop alcohol or any offending medication and recheck in a couple of months' time. If the elevation persists, then further workup is needed. ALT and AST, as you are aware, are enzymes found normally in liver cells, and they are released when there is liver cell damage. ALT is more specific for liver injury. AST could be found in skeletal and cardiac muscles. ALP and gamma GT, also they are found in hepatocyte and mainly that line the bile canaliculi. The level is raised when there is biliary obstruction, which can stretch the bile canaliculi and raise ALP and gamma GT. The ALP is found in addition in the bone and the placenta. Gamma GT is found in the bile canaliculi itself and can be used in conjunction with ALP or alkaline phosphatase for predicting that the raise is coming from the liver. Gamma GT can be raised in number of medication, alcohol, and can be therefore non-specific. Bilirubin, as you are aware, the bilirubin is water insoluble product of heme metabolism taken up by the liver, conjugated to become water soluble, and that can be excreted in the bile and eventually into the bowel. The patient becomes clinically jaundiced when the bilirubin is 2.5 milligram per deciliter. If the patient vomits green material, that indicates that the bowel obstruction is below the ampulla of Vater. Now, just to remind us about the physiology of direct and indirect bilirubin, the prehepatic disease such as hemolysis cause high bilirubin, which is non-conjugated or indirect. Fraction is higher. The hepatic disease can increase both the direct and indirect types of bilirubin, and the posthepatic usually is conjugated or the direct type of bilirubin, and that will cause dark urine and pale stool. When we have abnormally raised ALP, we think about hepatic causes such as primary biliary cirrhosis, primary sclerosing cholangitis, gallstone disease, medications such as tetracycline, oral contraceptive, certain antibiotics, infiltrative liver disease such as sarcoidosis, TB or cancer, pregnancy, and bone metastatic bone disease or Paget disease. All of these can lead to increased ALP. These are some ideas to help you to tell what is what. When we have hepatitis, AST and ALT are raised. When we have cholestasis or some form of obstruction to the bile flow, the total bilirubin and ALP are both raised. ALT is more specific than AST in liver disease. The methods to measure the functionality of the liver include albumin, coagulation, and bilirubin. In alcoholic hepatitis, AST is more than ALT by 2 to 3 times the ALT. And thus that can happen also with non-alcoholic fatty liver disease. When we have hepatocellular pattern of jaundice, the transaminases are usually raised, such as in viral hepatitis, drug-induced hepatitis, alcoholic hepatitis, autoimmune disease, non-alcoholic fatty liver disease, and hematochromatosis. When we have cholestatic pattern of jaundice, we have increased ALP along with bilirubin, and the transaminases can be raised, but not to the degree of when we have hepatocellular jaundice. And condition which could be considered cholestatic include gallstones, primary biliary cirrhosis, sclerosing cholangitis, and periambulary tumors. When we have abnormal liver function with high ALP or total bilirubin without evidence of biliary disease, always think about infiltrative liver disease such as tuberculosis, sarcoidosis, or fungal infection, or metastatic disease. Workup starts always by history and assessing risk factors. Imaging and biopsy probably isn't always needed. Primary biliary cirrhosis usually comes in middle-aged women, and it's more frequent in females. 9 to 1. The ALP is usually raised. The main symptom is itching along with jaundice, stimulation and osteoporosis. Xanthomas and xantholismans are present. Hypercholesterolemia with low-risk coronary artery disease. Diagnosis is usually done by antimitochondrial antibodies, AMA, with 98% accuracy. Liver biopsy will show chronic granulomatous inflammation of the interlobular bile duct. Treatment: early deoxycholic acid. Advanced condition, they need liver transplant. This is an ERCP of patient with primary sclerosing cholangitis, and as you can see here is PEDID pattern on the ERCP. The condition affects males predominantly with a ratio of 2 to 1. There will be intra and extrahepatic inflammation and sclerosis of the bile ducts. There will be strong association with inflammatory bowel disease, mainly ulcerative colitis. There will be cholestatic pattern of jaundice with raised total bilirubin and ALP. ANCA is positive in 80%. ERCP is diagnostic. Cholangiocarcinoma could happen in 15 to 30% of all affected patients. Treatment: stenting of the structured areas. Liver transplant is the definitive treatment. Non-alcoholic fatty liver disease affects 5% of the population, and the risk factors mainly obesity and diabetes mellitus, pregnancy, and TB, and additional risk factors. Diagnosis usually on imaging such as ultrasound or CT scan, which shows hepatomegaly and fatty infiltration. Biopsy will show steatosis and necrosis. If it's not treated, 1/3 of those people will progress to cirrhosis. Treatment: they need to reduce weight with diet and exercise, control their diabetes, and lower the lipids in their circulation. Hepatocellular carcinoma, the risk is mainly in patients with cirrhosis and usually with hepatitis B and C, exposure to Aspergillus flavus toxin or aflatoxin. All of these are risk factor for hepatocellular carcinoma. Screening by alpha-fetoprotein is mandatory in patients who suffer from cirrhosis. If the alpha-fetoprotein is raised, then ultrasound scan is needed. Unfortunately, less than 15% of affected patients, they have resectable disease at the time of diagnosis. You can see here a spot of metastasis on this liver, and if you find that incidentally at time of surgery, don't biopsy it, because that can preclude future surgical resection. And this is an image of non-colorectal liver metastasis. Here, just to show you the prominent veins, or what we call caput medusa, in a patient with chronic liver disease. Here you can see the clubbing, finger clubbing. Here, gynecomastia. And the slide shows jaundice, abdominal distension due to ascites, umbilical hernia. Child-Pugh classification is a good way to classify the severity of liver disease, and it depends on 5 main criteria: bilirubin, albumin, PT, ascites, and encephalopathy. Liver transplant is the treatment of choice for end-stage liver disease, confined liver cancer, and fulminant liver failure, which is not responding to supportive measure. Need to consider it in all patients with decompensated cirrhosis, or people with primary biliary cirrhosis with intractable pruritus. Contraindicated if the patient still suffering from alcohol abuse or alcoholism, metastatic cancer, severe lung or heart disease, or HIV infection. Liver trauma is the commonest cause of death in the young population, and the third commonest cause of death for all age groups. It's a preventable cause of death, and it requires a prompt assessment and treatment, and the presence of trauma center might reduce the mortality and morbidity from liver injury. You can see here a bullet injury in the liver. The mechanism of liver trauma could be, or actually abdominal trauma in general, could be classified into blunt and penetrating, and the blunt could result in multiple injury. The mechanism could be direct shearing or deceleration injury. The penetrating could be gunshot or stab wound. Are the main guidelines of treatment. Any patient with gunshot should be operated. Stab wound, operate selectively. Blunt trauma, also operate selectively. This is a CT scan grade of liver trauma from 1 to 6, which will help you in future management of patient with liver injury. Grade 1 and 2 usually managed conservatively. Grade 3 to 5 needs surgical intervention. 6 usually is incompatible with life. The prognostic criteria mainly depends on the hemodynamic status of the patient. The grade or the degree of hemoperitoneum or the CT scan finding usually does not predict the prognosis. If you are planning to do a surgical intervention in patient with liver injury, plan it early and do generous bilateral subcostal incision. The vascular control is by doing initially a Bringle maneuver or aortic clamp to reduce the blood flow to the liver. Always allow the anesthetist to resuscitate before taking the patient to theater. Packing is a very good way to control the bleeding as well. And this is just to show you how to do the Bringle maneuver. You pass the clamp around the Winslow foramen, and you clamp the hepatic pedicle, which will contain the hepatic artery and the portal vein, and that's helpful in most types of liver injury. Limited mobilization of the liver by dividing the falciform ligament will help. Packing will compress the majority of injured livers, and you should always avoid compressing the inferior vena cava and avoid lifting the liver up and avoid increasing the intra-abdominal pressure. Complication of liver injury include sepsis, biliary leak, structure, hemophilia, aneurysm, and aortoportal